For those of you that don't know me, I am Judy Katz. I'm administrator for the Winchester Seniors Association. We're delighted to have everybody here today. And we are absolutely delighted to have Jason Lewis with us here this afternoon. Rep. Lewis he serves as our state rep for the 31st Middlesex District, representing the people of Stoneham and Winchester. He's no stranger to the Senior Center. He's been here many times addressing many important issues, and he's been an avid supporter of our senior community. Rep. Lewis was first elected to the Massachusetts House of Representatives in 2008. He serves as the Vice Chair of the Joint Committee on Public Health, and he serves on the Joint Committee on Children, Families, and Persons with Disabilities, and the Joint Committee on Healthcare Financing. Jason co-founded and serves on the House Chair of the Legislative's Prevention for the Health Caucus. Jason was born in South Africa and came to the United States with his family when he was 12 years old. He went to Harvard College and has a degree in economics and a Master's of Administration degree from Harvard in 1995. Let's have a very warm welcome for Jason Lewis. Thank you.
Thank you very much, Judy. We hardly even have to raise the microphone. Very tall. Well, good afternoon, everybody, and I'm just delighted to be with you and have a chance to talk together about a very important topic that we all care a lot about, whether we're seniors or juniors, and that is our health care. I want to thank Ruth for inviting me to join you today and to participate. I very much appreciate the opportunity. Make this a little bit interactive. So what we'd like to do actually is, before we really dive in, is to hear some of the questions and concerns when it comes to healthcare that are on your minds. So Laura's going to capture those up here. And one of the reasons is that as I go through the presentation, I want to try to address as much as I can those questions and concerns. And then what we're going to do for questions you might have, anything related to healthcare, if we don't address it in the forum today, we will write that answers up afterwards, and we will make sure those get back to you through either directly or through the newsletter. Okay? So here we go. First was about the challenge of finding comprehensive coverage. You know, you might have your hospital coverage, but not dental, or maybe not vision. How can you get sort of affordable coverage that meets all your needs? The gentleman's question now is about the durability of Medicare. I assume you're referring to the sustainability of funding for Medicare, right? So we know we can count on Medicare into the future. That was about reimbursement for alternative therapies. You want to give one or two examples of things you have in mind?
Massage,
Okay.
acupuncture, all the ancillary things that are very, very important, and people do, but they have to pay out of pocket.
Okay. Question there is about when if you're admitted you have to go to the hospital, whether you're treated as an inpatient or outpatient, and that's observation, right? Okay, yeah, and that affects reimbursement rates and also nursing, skilled nursing care right afterwards. We hear lots of different things about the Federal Affordable Care Act, also known as Obamacare. What's really going on? What can we believe? And what does it mean for us, for each of us, right? Okay, we will definitely touch on that. So everyone heard that, the concern about how costs of healthcare seems to keep going up and up and up, and outpaces our sources of income, like our Social Security or pensions. The question is, how is it possible that you can get a relatively simple procedure done and it can cost an extravagant amount of money, and what's behind that, and what can we do about that? And I might add, the corollary to that is, it depending on where you're treated, the price might be $100 or it might be $1,000 all over the place. And most of the time we don't see that directly ourselves. It's so hard to know, what different medical costs are, and to be able to make better choices. It's so true. I mean, we shop around for everything else. We can go on the internet, we can go to the store, we can get information, tons of information to buy a box of cereal. But when it comes to healthcare, right, it's so difficult to know what we're getting, what we're paying for, what the outcomes are, how good is that doctor or that hospital. Okay, all fabulous questions, and I'm pleased that what we've prepared is going to address a lot of of your questions. And again, if there's something we don't get to, we will make sure to to follow up on that. Okay, so let's go forward, Shalane. This is what we're going to cover. We'll first do just sort of an overview of the healthcare landscape. So that will touch on a number of the things folks raised here about healthcare costs and the Affordable Care Act and changes that are ongoing at the federal level and the state level. Then we'll get into Medicare. Just by a show of hands, I assume virtually everybody in the room is a Medicare beneficiary. Is that correct? Just raise your hand if you are. Okay. Okay, so almost everyone. And then we will talk a little bit. We'll take out our crystal ball and look a little bit what we can expect in the years ahead. And then I hope to have still plenty of time at the end for more questions and discussion. And also to frankly hear your feedback. As a policymaker, and as you said, I have the privilege of serving on 2 important healthcare committees in the state legislature. So, it's very helpful to hear your feedback as well about things we could be doing differently or be doing better when it comes to healthcare policy, particularly in my case at the state level. Okay, so let's dive in. In terms of the healthcare landscape, the first thing that is an underlying factor, which was raised by your comments, is rising costs, and this is I think is the single greatest challenge to us when it comes to healthcare, and this is true whether we're talking about private health insurance, Medicare, or what's known as Medicaid. Some of this is for good reasons. We have some of the best hospitals and doctors anywhere in the world, particularly in the greater Boston area where we live. There's lots of research and innovation that is ongoing in the medical industry and healthcare, and that leads to wonderful new technology, new scanning technologies, new treatments for diseases, things that save lives and lengthen our lives. But all of these new innovations and technologies are also very costly, so that's one of the things that is driving up costs. There's also a lot of inefficiency in our healthcare system for some of the reasons you mentioned. There's not a lot of transparency. The market doesn't function the way almost any other market does. And frankly, healthcare is different. Healthcare is not something you choose. Healthcare is a basic human need. And it's very different from buying a car or choosing, what type of cereal you like. So it has, particularly in the last 10 years, we have seen costs for healthcare rising much faster than inflation. And that is a major squeeze on our own budgets as we have more out-of-pocket costs that we all have to bear, co-pays and deductibles and co-insurance. I will tell you it also is the single biggest challenge to our governments. This is true in Winchester at the local level, healthcare costs for teachers and firefighters, police officers. It's true at the state level. 10 years ago, healthcare consumed about 25% of our state budget. Now it's 40%. 25% up to 40%. What that means is the resources available for everything else that we need to do, schools, public colleges, roads, bridges, transportation, the parks and beaches, everything else that, our correctional system, the judiciary, everything else is squeezed as a result of those rising healthcare costs. And then at the federal government, we know that Medicare costs are one of the biggest challenges facing our federal budget. And we'll talk more about that. So that's one of the big underlying factors that makes healthcare so challenging. Another is what I call an epidemic of chronic diseases. As a nation, over the last several decades, we've become much more sedentary. Our children, not as true maybe in this community, but certainly in less affluent communities, many children, don't get the physical activity they used to get. They don't just come home from school and run around with their friends. They're much more sedentary. And our diet, yep, they're playing video games. And our diets, unfortunately, have changed for the worse. We have a multi-billion-dollar packaged food industry that promotes lots of packaged foods, many of which are really not very healthy for us, as well as the fast food industry. So that has led to, we have now about 2/3 of Americans that are either obese or overweight, about 1/3 of children, and that leads directly to a whole range of costly and preventable but costly diseases, type 2 diabetes, heart disease, stroke, certain forms of cancer, and various others. And so that's another major driver also of rising healthcare costs, because of the fact that we as a people, as a society, unfortunately are less healthy. There is, in response to both the rising costs and this epidemic of preventable chronic diseases, there is a growing focus on prevention and wellness. And I know you have great programs, here right at the Jenks Center. We're doing much better in our schools. And Massachusetts actually is a leader in the whole nation in terms of trying to promote wellness among all populations. So I'm always an optimist, and I believe we are going to start turning the corner, on this. And I think if we can become generally healthier, we will live longer, more productive, happier lives, and that will help to, over time, start to bend the cost curve when it comes to healthcare costs. And then last is one of the challenges and frustrations I think we all have is healthcare is so fragmented, and I'm sure this is true more so for our seniors. You have different issues you're dealing with. You may take multiple medications, see different doctors for different things, and to date, up till now, so much of that care is not really well coordinated. There's not always necessarily good communication, between your different healthcare providers. Well, the good news is that there's a major push underway, and I'm going to talk more about this, to improve how people receive their care, so that they get a much better primary care, and their specialist care is much better coordinated. Electronic health records are part of that. Accountable care organizations, medical homes, there's lots of terms that are thrown around, but essentially what they're all about is trying to essentially flip our healthcare system on its head. Today, what we really have, if you think about it, is a sick care system. You enter the system when you're sick. That's when you go to the doctor, that's when you go to the hospital. What we really should have is a well care system, which is how do we make sure that we keep people as healthy as possible, keep them in their homes, in their communities, out of the hospital, out of the nursing home, and as much as we can, and sort of turn the model on its head, if you will. That will make us all, I think, healthier and happier, and that's the way to really get a handle on costs over the long term. So those are some of there's certainly other trends and things going on, but just wanted to highlight a few. And then two major pieces of legislation that are affecting all of us, and which we're going to talk about, are obviously the Affordable Care Act, which is commonly known as Obamacare, at the federal level. And that was passed a few years ago, by Congress, signed by President Obama. And then at the state level, fewer of you are probably familiar with the legislation that the Massachusetts legislature and Governor Patrick enacted last year, which is known as Chapter 224, payment, and it's known as the payment reform. And I want to get into that as well. All right, so let's go to the next slide, Shirley. Okay, so let's take a look now at the Affordable Care Act. So a number of you asked about Obamacare and what it is or it isn't. And it saddens me that this has been so controversial from the beginning, because I think the result of that is that it has been very difficult for people to get good, clear, accurate information, and that really muddies the waters. Regardless of how any one of us feel about what the legislation does, there hasn't been good, clear communication about that, and I'm sure there's plenty of blame to go around for that. But essentially, well, first let me say, what I would like to see in terms of health care is essentially an improved or enhanced Medicare for everybody. That's what I would like to see. I mean, that's what we have in virtually every other advanced country in the world. And everybody basically pays into the system, and everybody can rely on health care coverage from cradle to grave. It takes health care, it's not something you have to get through your employment. It's not something where you have to deal with different insurance carriers necessarily, but it dramatically simplifies it. That's not what we have in this state or in this country, and it's probably not where we're going to end up, anytime in our lifetimes. So the next best thing is to try to say, well, since we're not going to let people die on the side of the road as a society, most of us wouldn't condone that. We are going to basically treat people, we're going to admit them to the emergency room. So essentially, if that's the case, then wouldn't it be better if we tried to ensure that everybody did have insurance, so that rather than waiting till they're really, really sick and have to go to the emergency room, they can actually get access to health care, they can get the treatment that they and their family need, when they need it. So what Massachusetts did back in 2006, and this was bipartisan, we had a Democratic legislature, we had a Republican governor, was basically to say, let's put in place a system where we essentially require everybody to have health insurance. Many people have it already, great, they're all set. And those who don't have it, we're going to require you to have insurance. And if you are unable to afford it because you don't have the income, you don't have the resources, we'll help you pay for it. We'll essentially subsidize your health insurance. And that's fundamentally what we did in 2006. There's a lot more to it, but fundamentally what we did. And that has been largely very successful in Massachusetts. We have about 98% of our population that has health insurance. Almost every child in the state has health insurance. So people don't go to bed at night worrying about going bankrupt because of being one illness away or one accident away from bankruptcy. They can count on care. That doesn't mean there's not still affordability issues. We know people still have to spend a lot of money out of pocket, unfortunately for things like co-pays, deductibles, but at least they know they have health insurance. So what the Congress and the President really set out to do several years ago was essentially to take the Massachusetts model and just roll that out on a national level. It was simply that. It was what we did in Massachusetts as a model and taking that to the country. So these are basically all things that have existed in Massachusetts since 2006. So you've all lived with it, and you know whether you like it or not, but as you know, it certainly didn't end the world. In Massachusetts, it's done fine. Our economy has grown faster in most regards than the rest of the country. Our healthcare costs, have been in line with the rest of the country. And we do have, as I said, virtually all of our population does have access to health care. So market reforms, basically to ensure that people can get insurance, that you're not unable to get insurance because you have a pre-existing condition or you've reached a lifetime coverage limit. So that's the first major piece of the Affordable Care Act. Those were insurance reforms. Okay. Expanding coverage for young adults, so up to age 26, they can still be on their parents' health policy. The individual mandate, which is the piece I talked about, that everyone does have to, with a few, there are some exceptions, but in general have to have health insurance. The health insurance exchanges. Basically, all this is a fancy website. We've had it in Massachusetts again since 2007. It's called the Healthcare Connector. You can all see it if you go online. Basically, all it is a place where you can compare different private health insurance plans. So if you go on the Connector website, you'll see there's Blue Cross Blue Shield, Tufts, Harvard Pilgrim, and people can look at that, and this is very helpful for small businesses as well. They can compare in an apples-to-apples way, different plans, what the coverage is that the plan offers, what the costs are, what the co-pays are, etc. That's what these exchanges are intended to do. And frankly, use market forces to promote more competition among these insurers so that hopefully you get lower premiums and better coverage for individuals and small businesses. Okay? And then for those people who can verify that they don't have the income or the assets to afford the insurance policy, that there is assistance to help them, and it's essentially a sliding scale of subsidies for those. By the way, all of this we're talking about here really doesn't apply to Medicare. This is all about insurance for people who are under 65, who don't have access to Medicare. We will get to Medicare a little later, but just this is kind of a background in terms of what's happening out there in the landscape. Next slide, Shirley, just finishing up. So the Affordable Care Act does have a very significant focus on prevention and wellness. This is one of the areas I've personally been involved in. I actually sit on the advisory group for we received a multi-million-dollar grant from the Centers for Disease Control through the Affordable Care Act that's focused on health and wellness in Middlesex County. So we've got all kinds of programs underway to promote, for example, tobacco cessation, get people to smoke less, to encourage more physical activity in children. You may be familiar with the Shape Up Somerville program that's been very successful. That's a model we're trying to replicate in a lot of communities and encourage more health and wellness. Another important provision is you may not know what the medical loss ratio is, but essentially that's the proportion of what insurers take in premiums. How much of that do they have to pay out to doctors and hospitals? In Massachusetts, for example, our insurers are virtually all nonprofits. They run a pretty tight ship, and they pay out about 90 cents on the dollar. So, Blue Cross Blue Shield in Massachusetts, Harvard Pilgrim, Tufts, they pay out about 90 cents. In other parts of the country, insurers in some cases pay less than 80 cents on the dollar in healthcare. The other 20 cents is going for their administrative costs, their marketing costs, their profit. They're for-profit insurers. So this requires that insurers pay out at least 80%. As I said, in Massachusetts, we're already way beyond that. We're at 90%. I should add here, by the way, that does anybody know what the the overhead, essentially the medical loss ratio is for Medicare? Anyone have any idea? Any guesses? It's about 2%, 2 to 3%. So Medicare actually runs much more efficiently than does virtually any private insurance out there. So in other words, the money that Medicare takes in through the payroll taxes we pay, through the premiums that seniors pay, through other revenue sources, 97 cents on the dollar is essentially going to pay for actual health care. So pretty good, pretty good actually. And lastly, the part of the Affordable Care Act that got a lot of attention because this went before the Supreme Court was the issue of whether states will expand their Medicaid program. In Massachusetts, this is known as Mass Health. And what the federal government was saying is essentially we'll pay for this for 3 years, and then after that we'll pay 90% of the cost to basically allow more people to qualify for Mass Health, which is for people that are low income, single parents, children, or those who have disabilities and are under 65. Massachusetts was very happy to take this because we were insuring most of these people already, and now we get more federal dollars to help us pay for that. So we actually are going to be reaping some significant benefits as a state over the years ahead. But as you know, about half the states decided not to do this. So there will be people in their states who would now have qualified for health insurance who will not be able to have access to health insurance, which I think is very sad. So now moving on from the Affordable Care Act, which is federal legislation, to some changes in Massachusetts. So this is closer to home. I mentioned 2006 when we first passed healthcare reform, and that was to basically get everybody insured, get everybody in the system. That became the model for the Affordable Care Act. What we've been tackling since then is that the challenge of healthcare costs and quality. It's great that people hopefully can afford and have access to affordable insurance, but if your healthcare is still too expensive, and if the quality is varied between different providers, that's still major issues we have to tackle. So we've passed various legislation over the intervening years to try to encourage ways to get lower costs, ways to increase use of electronic medical records, get drug costs down, things like that. But this piece of legislation, Chapter 224 last year, I think was a major, major accomplishment. I don't know how many of you have heard about it. It didn't get nearly as much attention as Obamacare. But I actually think this legislation and also what's happening in Vermont right now, where they actually are trying to implement a single-payer healthcare system, are the two most innovative, most forward-looking healthcare policies in the country. So we'll see, whether this latest round of reforms in Massachusetts and also what Vermont's doing, how that will, eventually potentially roll out in the rest of the country. What Massachusetts payment reform, some key aspects of that is, for the first time ever, we have set a statewide growth target for healthcare costs. So we've essentially said healthcare costs in Massachusetts will not grow more than our state economy. And we've got some various provisions in the law and mechanisms to try to keep us within that overall cost growth goal. So that's the first of its kind anywhere in the country where we've tried to set a goal and keep healthcare costs in total, to within something that will be affordable for all of us. The second key aspect of this is really to move away over time in a gradual fashion from what we have today, which is largely fee-for-service. Today, each test you get, each time you see the doctor, or each time you're admitted to the hospital, have a procedure, there's a charge. The healthcare provider charges the insurer or charges Medicare, and there's payment for that on a transactional basis. There's lots of research and evidence that shows that encourages more care, higher quantity of care, but not necessarily higher quality or better outcomes or healthier patients, which is what we really care about. So there are ways of organizing care and paying for it that have been demonstrated here in certain pilot programs in Massachusetts as well as in other states. They can do a much better job of actually controlling costs while delivering better coordinated and better quality care. So this legislation is going to really help push us over time away from fee-for-service. There will be much greater transparency of costs and outcomes. A number of people brought that up. So there are requirements that costs for different procedures, that the quality of different healthcare providers and doctors, all of that kind of information will be available to the public. It will be, have to be on websites. Some of that will be, through the state's Health Policy Commission website. Some of that will be disseminated in other ways. But the idea is to share more information with patients and consumers and allow each of us to make better decisions, frankly, and be better shoppers, if you will, when it comes to our own healthcare and our own decisions we make. Also, very significant administrative simplification. So today, one of the complaints you hear from doctors, healthcare providers, is each insurer requires different paperwork. They have to have office they have staff in their office just to help them take care of the paperwork, and that's not productive. So this will move us towards standardization of these forms and paperwork that healthcare providers would submit to their insurers. So that should make it much easier for them. Also, some medical malpractice reforms. Sometimes you'll hear, well, one of the reasons healthcare costs are high is because we're a very litigious society, and doctors and hospitals have to worry about that, and that pushes up costs. That's largely, there's some truth to that, although that is not one of the main factors that are driving healthcare costs, but it is a factor. So there are we're the second state, I think, after Michigan to enact some reforms in this area, and I think we'll see how that works out, and if that also helps to take some of the pressure off of liability policies for doctors. There's a few other things in there. The last one is something that I was personally involved in. It's legislation that I filed that was incorporated as part of Chapter 224, and it establishes a prevention and wellness trust fund. It's funded with $60 million, and that was the first of its kind in the nation, actually. And that now will be able to provide significant grants directly to communities for programs that really impact health and wellness. One of the main focus areas of those grants is going to be preventing falls. Mostly which affects the seniors. So the 4 areas that they're going to be focusing on with these grants to start out is prevention of falls, tobacco prevention and cessation programs, hypertension, and chronic asthma in children. The reason is those are 4 conditions where we have very good data that shows we know how to prevent these from happening, we know what it takes, and there's a very good return on investment. So if we invest $1 to prevent these things from happening, we can see a return of $2, $3, $4 in savings because of that intervention. So I'm actually hopeful that, I know Winchester Hospital has been doing great work in this area of prevention and community health, and I'm hopeful that they are going to be part of a coalition, along with some of the towns in the area, along with some of our potentially home care agencies like Minuteman and others that will be applying for one of these competitive grants to do some of these programs right here in our own community. So that process is underway right now, and we'll see, we'll be watching that closely. Okay, so let's move to, so that's kind of the overall landscape in terms of federal legislation and state policy and some of the trends. In terms of Medicare, let's move to that next. Okay, thank you, Charlene. So I think everybody probably knows this already. I mean, you know that Medicare's, the parameters of Medicare. I mean, you know it covers certain services, but doesn't typically cover others, like nursing home, and we mentioned dental came up, right? So we mentioned home care services and other things. It is administered by the Federal Centers for Medicare and Medicaid Services. So Medicare is really a federal program. At the state level, we're actually not really involved much at all in Medicare. We focus more on Medicaid, or Mass Health, which is a partnership between the federal government and the state government. Okay. Next slide. Again, I think you all know this, right? The different parts to Medicare, and some of it. If we go to the next slide, these I'm sure are questions that many, if not all of you in this room, have asked at one time or another, or maybe asking right now. In terms of what decisions you should make when it comes to Part A, Part B, Medicare Advantage, Medigap. How you get the best overall coverage to meet your unique needs at the most affordable cost. So there's a lot, these are some of those questions, and there's others. Some of the resources, this is not the best forum today to try to answer those questions, both because I'm not an expert on Medicare, and I wouldn't presume to try to help you answer those questions. And also, in many cases, it's a very unique conversation. It's a very personalized conversation, right? Each of you knows what your health conditions are, what medications you may or may not have to take, which doctor you like to see. So that really has to be something that you work out, for yourself in terms of what the right coverage is, or changes you may want to make. But there are some terrific resources. If we go to the next slide, there are some excellent resources that are available. First and foremost are the Shine Counselors. Are they the Shine Counselors with us today? Are they Ruth, are they here? They're not actually here today. Minuteman was here earlier, okay. But just by a show of hands, are you aware that there are these counselors that are here at the Jenks? Okay. For those of you who are not aware, they're a terrific resource. And you just, I think the process is you just, schedule an appointment. Right.
We call them up and they call them.
Yep, they call you directly. So that's a one-on-one conversation. You don't have to pay for that. That's free. It's a service, through the Senior Association and Minuteman, and they can really help understand what your needs are and work with you in terms of decisions you make around Medicare. Just some other resources. There is the toll-free number that Medicare has, and that's a pretty good resource. There's some excellent websites. Medicare.gov. You may have seen that one. Healthcare.gov is the new website as part of the Affordable Care Act. And then AARP, has some great resources here. I'm sure many of you are aware of that already. So those are good resources. I do a lot of work also with Healthcare for All. They're a nonprofit organization in Massachusetts, and they don't only work with seniors. They help with healthcare questions for everyone, but they are really responsive. They really help get answers for us. So that's another resource for you. Okay, so let's move on now to, went the wrong way. So what can we expect going forward? Okay, this is the right side, I'm sorry. All right, so looking forward now, kind of our crystal ball. First thing, the impact of the Affordable Care Act on Medicare, on all of you sitting in this room. The most important point is really very minimal impact on Medicare in terms of what you would see, day to day, with two main exceptions, which I think most people will probably feel are pretty nice changes. So you don't have to make any changes to your Medicare coverage as a result of the Affordable Care. What does happen now is that more preventative services are going to be covered at no charge. So with no copay, no co-insurance. So things like mammograms, colonoscopies, an annual sort of checkup wellness visit, if you will. So Medicare is basically now encouraging more seniors to get those basic screenings and checkups, and not have cost be a deterrent. This is great news. This is great news. I think it's a way to make sure you stay healthy. You have these screenings, and if there's anything that they turn up, you find out as early as possible. So that's one of the benefit changes that will be benefit Medicare recipients. And then the second main one is that the donut hole is being closed. It's being closed over time. So I believe by 2020 it'll be completely closed, and so that will no longer fall as a cost on you within Part D. And then last year, just looked this up to see, that was the average savings on prescription drugs for Part D beneficiaries. It's almost $600 in savings because of the donut hole being closed. So there's a range of other things that healthcare providers will, I think, benefit from. Some of the things I talked about before in terms of improving electronic health records, improving coordination of care, all of those things that will benefit the general population in terms of receiving, hopefully over time, higher quality care at more efficiently, will also benefit seniors too, because you're seeing many of the same healthcare providers. So that's a general thing that should help. And then the legislation did also extend the life of the Part A trust fund till 2029. So it's not an immediate risk of running out of funds. It's not completely stolen for the long term, of course, but that was, I think they extended it, 12 years through some of the funding and changes that were made by the Affordable Care Act. Okay, so that's the impact on Medicare. Again, the bottom line is, I think, some good things, and not otherwise not any really significant changes. That you may have heard about. There's been some talk about like a Medicare tax, things like that. That will affect a very, very small percent of the population. I think it's about a 3% surtax, but only on investment income over $250,000 for a married couple. So it's not. So it would be folks who are doing very, very well and have very, very significant investment income. There is a slight additional surcharge there, which is one of the ways we extend the life of the trust fund is by bringing in a little more revenue. But that has been thrown out there, and I know a lot of people have been scared about whether there is additional tax that they have to pay and on the sale of their house or whatnot. As I said, there may be some in this room that impacts, but I think it will be generally a very small share of the population. So some of the challenges facing Medicare, and this goes to some of the questions you also raised. There's no question that rising healthcare costs are a challenge to everybody and all of our budgets, business budgets, family budgets, government budgets, including Medicare. Also the aging population. The total number of Medicare beneficiaries is expected to double between 2000 and 2030. So we will go from about 40 million recipients of Medicare to 80 million by 2030. So that is a major challenge. We have a lot, obviously, as the population ages, people are living longer, there will be more people on Medicare. Also, corollary to that is people are having fewer children, so we have fewer workers per retiree to actually pay payroll taxes into the system, which is helping to support the benefits. The funding shortfall after 2029, we just mentioned there was an extension to it, but after 2029, at least the Part A trust fund, will start to be taking in, is projected to take in less money than it would be, paying out. So that's the challenge. And then, of course, we all know problems we have with the federal budget. We don't have to look any further than just what happened over the last several weeks in the ongoing battle in Congress over what to do about our nation's budget and our nation's debt. So unfortunately, Medicare, Social Security, defense spending, all of these things are part of that broader discussion as to what we do going forward. Some of those are the challenges. So when we look at, how we would ensure the long-term solvency of Medicare, I think we know difficult decisions will have to be made. They'll have to be made by Congress, by the President, citizens, all of us, will need to pay attention, have our voices heard. Groups like the AARP, are doing a great job being knowledgeable on these issues, speaking up for seniors and others, advocating. But it's something we all need to stay involved in, read up on, be aware of what's being discussed. Some of the options, I'm not endorsing any of these options, I'm just putting out there what some of the things are that are, have been brought up, mostly in Washington. Would be things like raising the eligibility age over time from 65 to 67, which would be the same age as Social Security for full Social Security benefits. Raising the premiums, Part B premiums for potentially for upper income beneficiaries, potentially more co-pays for certain services that don't have co-pays today. Increasing some of the penalties, deterring fraud, which on its surface sounds like a good thing. Why, of course we should have greater penalties. We should do everything we can to deter fraud. But it is a balancing act, because if you push too hard, then more doctors and healthcare providers will just say, I'm not going to take Medicare. And they're too afraid of then running afoul of doing something wrong. So there's a balancing act there. And then potentially, do we raise the payroll tax rate so future workers maybe pay a bit more, employers pay a bit more into the system. So all of these will have to be debated. They are being debated. I'm sure all of you have opinions, one way or the other, on these. I think the last point I want to make, before we wrap up and get into discussion is any of these future changes are unlikely to significantly impact, today's Medicare beneficiaries. So all of you sitting here today, I think these sorts of decisions, these changes are probably going to have minimal impact, on you. And I think, so, hopefully you can, sleep well at night and not, have nightmares about, Medicare is not going to be there for me tomorrow or next year, and it's going to go bankrupt, or all kinds of other scenarios. I think that, notwithstanding the dysfunction we have in Washington, unfortunately, I don't think Medicare is going anywhere, and you can continue to count on your coverage. I know it's still difficult. There's still lots of out-of-pocket costs, that you have to pay. But on balance, Medicare is still really excellent coverage, compared to a lot of private insurance that's out there, or people that don't have any, health insurance. So I think those changes that are likely to occur will probably affect more, my generation and Shalane's generation and Laura's, folks coming along in the decades to come. So we need to be part of that discussion and debate as well. All right, so that's kind of what we have prepared for the presentation. I hope you found that helpful and interesting, and answered some of your questions. And now I think we have some time. How are we doing on time? Yep, we do have about 10 more minutes for further questions and discussion. The question was about raising those premiums, and your point is that they're already going up. And absolutely, that's
No,
true.
I mean, they're going up
Yeah.
if your income is
If your income,
going up.
yes.
We're taking it from Social Security and
Yes.
raising the premium.
So-
And that was an unknown.
I understand there's different tiers today, right? I think there's maybe 3 tiers in terms of your income level and how much of a premium you have to pay, and that's deducted typically from Social Security. That's true, and that just went up. What's being discussed, I think some people say it should go up even more. What they would say is that for those Medicare recipients above a certain income level, that we should ask even more of them in terms of the premiums they pay. So I think that's what's being discussed. So there's 2 aspects to that, I think. One is how much Medicare actually reimburses for doctors and hospitals for actual services. And Medicare, as you know, I'm sure you've seen, I know that's not very transparent. You probably have seen this on statements. Medicare has an agreed upon rate that they typically pay, and generally that's lower quite a bit lower than the private insurance pays. It's a lot higher than what Medicaid pays, but it is lower. And yes, this is a constant battle in terms of pressure to reduce those rates. And essentially, for an MRI, to pay a lower rate of reimbursement than is the case today. And as you might imagine, doctors and hospitals, there's a constant tension over what those rates will be. So that's one aspect of it. The other is the even bigger issue of healthcare costs, in general, and what we can do to rein in healthcare spending. And that, as I said, I tried to say during the presentation, that is the major challenge. The Affordable Care Act does take some steps in that direction, although many people have criticized the law for not doing more around cost containment, and I think that's probably a fair criticism. But the Massachusetts law that I talked about, that's really what it's focused on, which is how do we bend the cost curve? How do we, instead of healthcare costs going up 4, 5, 6, 8% a year, how can we ensure they only go up 2 or 3% a year, or maybe even don't go up at all and go down? And that's the major challenge. That there's multiple ways of trying to solve that, focusing more on prevention and wellness, getting chronic diseases under control, better use of electronic health records, coordinating care through accountable care organizations, ways to rein in drug costs, trying to ensure more transparency so that the issue you raised earlier, where it's $800 to get your thumb bandaged, and from one doctor, but only $200 somewhere else, that we can bring down that cost by getting care at the most efficient and highest quality providers. So if the question was about the issue of how the cost of living is calculated for Social Security, right? And so I don't know. I would say it's another, that deals more with Social Security, although that impacts Medicare too. That would probably be another one we could put on this list. We probably should have, which is this change, using a different, essentially, way of calculating what the cost of living increase should be each year for recipients. And it's on the table. Again, there's a vigorous debate, about whether that's the way the country should go or shouldn't go. Just like there's a vigorous debate about all of these things. And I don't, at this point, no decision's been made. I don't think any decision's imminent at all, but it's something that's also considered. And basically, the idea would be the cost of living, the increase would be less. So from the federal government standpoint, costs would grow at a lower rate. But from the standpoint of all of us beneficiaries, it would mean we get a smaller cost of living increase each year. We can look up that and do some research. It's definitely a problem. Medicare is a huge program. I mean, it's a $450 billion program, I think, and there are, unfortunately, unscrupulous, people out there that try to cheat the system. I know they're, from what I read, they are, CMS, is trying to do more and more to catch those people and lock them up. It's a terrible thing that people do, that they commit fraud and basically steal that money. So I'm sure we can do a better job. I mean, we probably need to do a better job, but I can't speak to specifically whether, what we could be doing that or not. I mean, my guess is from looking at this in other programs that at the state level, this comes up with regards to food stamps or welfare, where unfortunately fraud is a problem everywhere. But in my experience when looking at this, typically it's, although you do have some high profile cases, often it's usually a tiny fraction of the total program, less than 1%. The question for those who didn't hear it is, why are we seeing these mergers? I mean, Winchester Hospital is a wonderful community hospital. We're so fortunate to have that in our community. They just recently announced a merger with Leahy, for those who maybe weren't aware of that. And they're just getting regulatory approval. And Hallmark Health, which includes Lawrence Memorial and Melrose Wakefield Hospital, right? And Witten goes okay, is going to be merging with Partners. Right. So what's going on? Why are we seeing this? I've actually had these very conversations with Kevin Smith, who's the president of Winchester Hospital. And it basically, it goes back to these underlying trends that we talked about. Unsustainable rise in healthcare costs. It just can't continue. We cannot have healthcare costs going up 6, 8, 10% a year, right? It's bankrupt in our country, all of us. In order to get a handle on that, we've learned that we have to do a better job delivering good quality care in a much more efficient manner, right? We cannot have, and it's estimated today that I think something like 30%, maybe even 40% of care that's delivered was unnecessary care. It wasn't needed. There's a great project that's been done at Dartmouth over the last several decades, and they've done these comparisons across different communities, different states, different healthcare providers, looking at the same exact, procedures, say heart surgery, looking at what it costs and what the outcome was for the patient. And they've shown that it's some astronomically high percent. I mean, the number ranges, but let's say a third, of money that's being spent today on healthcare really wasn't needed. So one of the ways that we're trying to get at that, it's not a simple problem to solve. One of the ways is transparency and increasing that. One of the ways is better use of electronic health records. But a big part of this is changing the payment system that I talked about. So when you have fee-for-service, it's just like it encourages. I don't think anybody does this maliciously. I mean, there's no doctors that are ordering tests just to get reimbursed more. I mean, I doubt that's the case. Or hospitals that are scheduling surgeries because of, But we have a system, unfortunately, that has perverse incentives, and that does encourage that. So we're trying to move away from a fee-for-service. What we're trying to move to is more of what's called a global payment system, which is essentially for each patient that's part of a network, that network will receive a fixed amount of money each year to provide care. And there's a whole complicated way of determining what that right number is and creating positive incentives so that if people are kept healthier, the healthcare provider receives more money, good positive incentives. Very different from the way we did HMOs, back in the 80s and the 90s, where people were concerned about having care withheld from them, not being able to get the care that they needed, and that's absolutely not where we want to go. So just to finish, because that requires these what I call accountable care organizations, it requires healthcare providers to be bigger because they want to be able to take care of all your needs. So you go in the door, you have a primary care doctor, and then essentially that's your medical home. And then let's say that's Winchester, you have a Winchester doctor who's your medical home. And then all of the other care you need ideally can be provided and coordinated for within that family. And they can control the cost, and they can provide better coordinated care for you, ideally take better care of you so you stay healthier and get the care you need, and also do it in a more efficient manner. So that's what we're driving towards, and that's what's pushing smaller community hospitals to recognize they can't go it on their own anymore. They have to be part of. So I think where we'll probably end up in Massachusetts with maybe 3 or 4, 5 big systems, which basically have all of the resources and the doctors and the hospital beds and all the services that we would need. So that's what's behind it. Yeah.
You talked about non-profit places. Well, Blue Cross Blue Shield is a non-profit place, and yet their CEO made $800,000 last year. How is that justified?
Yeah, I'm not going to stand up here and justify why their CEO should make $800,000 a year. What other thing I would say is, I guess it's all relative. And the CEO of Cigna, which is a private health insurer, I think made like $30 or $40 million last year. So as ridiculous as $800,000 is, I guess it's nothing compared to what the CEOs of private health insurers make. But yeah, that's a discussion for another day, right?